book which is authored as well as co-edited by me and the editor, Dr. Amal Kumar Dey, and it is AI in Medicine. I would like to present the book to Paras Healthcare. So, Nazir sir. So, this is a small token of appreciation. Please, if you can come. Thank you so much. Before I begin, I apologize for the delay. It was not expected, but nevertheless, मैं पहले से शुक्रगुजार हूँ कि आपने ये CME organize की है. Really thankful for this opportunity to Paras Healthcare in Srinagar and for the doctors who are here for this particular session. I hope I make some difference, and of course, I mean not a lot, but yeah, a little bit at least. Right. So this is not the first time or even second time or third time in Srinagar. I have lived here and served here, so this feels home. I have served in some of the sectors before, but that was some time back. And from then, we have come a long way. And also some of the newer branches and some of the newer updates in medicine have come our way. And this is right now where we stand. Before this is a familiar frontline, but the topic, the subject that I am really going to talk today is different from what my specialty has been, community medicine. This is going to be digital health and not a lot of AI because we are not yet there a lot, but a lot has happened in digital health front. We have, let me just thank Nazir, Gyani sir and Dr. Murtaza sir and of course Dr. Shafkat Khan here, and then let's just start with very basic thing. Before we begin, let's just it's a show of hands. Before we begin, those who have used AI today, you can raise your hands. Those of you who have raised your, those who have used AI in today's day. Yes. What way have we used, sir? Yes, sir. Those of you who have not used, have we used Google Maps? Yes. So then we have used. Have we used WhatsApp? Yes. We've used either YouTube or Spotify. Of course, not YouTube during the hospital hours, but sometime Gmail or Outlook or even Pace ID. बिल्कुल ही काम में अगर आप व्यस्त हैं तो पल्स ऑक्सीमीटर कहीं ना कहीं यूज हुआ है, right? So what I want to really say is AI is not there or is coming. It's already with us and we're already using it, right? So it was a longish session and these were few of the topics that we were going to cover, but let's see how much the time permits, right? So it is the digital health landscape that we will talk about, AI from your phone to your ICUs, then coming to what is Sahi. So I hope people, amongst us, we have followed, the India AI Impact Summit. Sahi is one of the outcomes of that, and we will go through that. Then coming to building the digital cadre, how do we really train our doctors and how do we really want them to utilize or adopt digital health, and then coming to the intent and what action do I take today, this month, this year, right? Yes, so first and foremost, the digital health landscape. This is nothing but some of the data. So India's digital health data, we have some of the really, specialists, let's say, sitting here, so let me not go very much in detail, but did you know that J&K Union Territory ranks amongst the India's top union territories in ABHA ID creation per capita? We actually are leading. So the J&K Union Territory Health Services, GMC, and of course PARIS together hold some of the most clinically complex data in the country. And look at the India's healthcare AI market. US 1.1 billion to going to 5.4 billion, which is estimated or projected by 2030. We're sitting here at the cusp of a huge boom in AI and healthcare. It's going far faster than any other sector in India. These are some of the numbers against India and of the J&K Union Territory. I hope these are familiar numbers to all of us. Yes. So this is NFHS 5 data. This actually gives us a very good picture of how J&K is faring as against the Indian numbers or health indicators, right? So J&K Union Territory better on 4 out of 5 of these health indicators, and that gives us a vantage point from where. So when you start high, you can reach higher. So that's the very point of this particular slide. Why are we talking digital health, not everywhere else? I have seen PARIS has so many branches everywhere across the country. And why J&K? Because we are already ahead of the curve, ahead of the wave. And here is the largest opportunity for us to go, and be the leaders in Ayushman Bharat Digital Mission, which is the digital health backbone of India's digital health revolution. So ABHA ID, everybody is aware of ABHA ID, Health Facility Registry, Health Professional Registry. So I hope, so can you again let me know how many of us are already registered as health professionals? All of us? Few of us? It takes less than 10 minutes to get registered as health professional. Unified Health Interface. So yeah, coming to this particular, let me just ask you, a patient in Baramulla. Now everybody please you have to kind of answer this. A patient in Baramulla visits a new doctor in Srinagar for the first time. Using ABDM, the doctor can assess her complete 5-year medical history in under 60 seconds. What makes this possible? ABHA ID alone? It stores all records in the cloud? Yes. Okay. Thank you. Yes. Unified Health Interface. Thank you, madam. Clap for ma'am. So yes, ABHA ID is the key or the identity. UHI is the open protocol that lets ABHA linked record flow securely to the hospital or between the certified provider in real time. So that's the thing that we are. So ABHA ID is like UPI. We have talked about this. Everybody in every forum they talk about this. This is like ABHA is like a UPI of health data. And ABHA QR code stores an encrypted summary that works even offline at a remote PLC. ABDM 2.0, which is 2526, adds AI-assisted diagnostics integration in the insurance claim automation. That makes the insurance facility as well a little faster. India's ABDM is the world's largest open digital health ecosystem by population coverage. We all are very proud of this and we should be. A patient in Kanyakumari can share his or her record with specialists in Srinagar under 60 seconds, and that's the power. That's not even available. That kind of digitalization is not available in Europe. It is not available in any of the advanced countries, and we do have it. We have it And now, of course, ABDM 2.0 and National Health Authority, they are now talking about across the borders, not just within India, but the health records will be honored across the borders with various countries with whom we will be signing treaties, etc. JNK was amongst the early adopters, and we need to always, and ahead of the curve, we need to be early adopters, and also in the in the term of realization of the benefit, we need to be ahead. What changed in 25-26 from digitalization to digital transformation? The upgrade every clinician should know about. First is Federated Personal Health Record, or PHR. Patient Health Record lives in a distributed, secure locker. It is not kept centrally. So remember this is something which is different from the NHA, which is different from some other health systems across the globe. This is separate and this is federated personal health records which are kept distributed. Aadhaar linked prescription system which is existing. Ayushman Arogya Mandir integration, which is again a very unique system in India, and we are very happy that we can actually empower our PHCs. We can actually empower our peripheral systems with digitalization. AI integrated diagnostic support. ADDM 2.0 is enabling the certified AI diagnostic tools in the interface, and then claim automation, and of course regional language support. So these are this was a unique challenge for India. Again, हम लोगों के पास में इतने regional languages हैं that when we want to go peripheral, we want to go to PHCs, we really need to have that regional language support, right? Next is the DPDP Act, which is the second part. और जैसे there are two रथ के दो पहिए. So one would be ABDM and the second one would be DPDP 2023. There are 13 months left for the complete adoption of DPDP for a healthcare facility. Data fiduciary, every doctor and hospital collects patients' data, is legally a data fiduciary responsible for protection and use. Data minimization, collect only what is clinically necessary. If it is not necessary and you are collecting it, you have to take separate consent for it. Exporting bulk patient data from non-clinical purpose is under Criminal Act. Penalty is 250 crores. So it is. So of course, DPDP is always. It's still not an act. It is still in revision and it is still in consideration. But we still are 13 months away, and 13 months are not a lot for a hospital to adopt DPDP, or any solution that we are adopting for AI needs to be the Digital Personal Data Protection Act compliant. Then informed consent. So Digital Personal Data Protection Act says that if it is not an explicit consent, it is not a consent. So we need to have an explicit consent for acquiring any personal data. Digital consent must be explicit, informed and freely given before any health data is processed, and verbal consent is not sufficient. There has to be, अगर हम कोई भी app use कर रहे हैं, digital app, तो उसमें I consent या whatever it is, it has to be a very explicit tab or anything. If we are using a digital platform, an application for healthcare purpose, हम किसी पेशेंट को ऑनलाइन ट्रीट कर रहे हैं या टेलीमेडिसिन के द्वारा, तो हमें ये कंसेंट जो है इट हैज टू बी एक्सप्लिसिट. इट इज वेरी इंपॉर्टेंट. देन ब्रीच नोटिफिकेशन, ये बहुत इंपॉर्टेंट है. अ डेटा ब्रीच मस्ट बी रिपोर्टेड to the Data Protection Board of India within 72 hours. No exceptions. This had happened in AIIMS Delhi some time back, where there was a data breach, and there has to be a reporting of data breach when it comes to healthcare data. Now right now we are actually struggling to make healthcare data sensitive data. जब वो हो जाएगा तब हम और भी ज्यादा, मतलब this will be all the more stringent. But right now, what we need to remember basic is within 72 hours, a hospital or a personal clinic, जो भी है, lab है, you have to please report it within 72 hours that there has been a data leak, there has been a corruption of the data or a data breach, या जो भी है, या phishing attack, जो भी है. Patient right. Patient has given legal right to access, correct, nominate and withdraw consent at any point of time. Coming to the next again question. Dr. Suresh is HOD at a busy hospital. Ransomware attack exposes 8,000 patient records including HIV status and psychiatric diagnosis, etc. Hospital's IT team advises him to stay silent, change password and wait for legal guidance. It is 11 p.m. on Tuesday. Under the DPDP Act 2023, what is the first legal obligation for Dr. Suresh?
Option B. Option B.
That was very quick. Absolutely. Option B. That has to be that quick. Thank you, sir, for that. We need to clap. Yes, it has to be without fail. This has to be reported. Report to Data Protection Board within 72 hours. Data fiduciary under DPDP 2023. His first obligation is notification of to the board. Even at 11 p.m. on Tuesday, ignorance is not a defense. So we need to, as doctors, we need to see, we are a part of an organization. So many a times we say कि हाँ hospital देख लेगा, administration देख लेगा. But as a doctor, we need to be aware of this responsibility which is at a personal level. You as a doctor, me as a doctor, we need to be responsible because ultimately it is us who make the system, right? So data fiduciary duty is you are personally responsible for the patient data that is collected, used or protected in your facility. AI tool contracts, any AI tool that you adopt must have DPDP compliance, compliant data processing agreement. Read the fine print or consult somebody, not like me exactly, but then you have to be, consulting somebody who is aware of the things. There has to be an aware or informed decision from the doctor's side. ठीक है. Gone are the days where they say that मैं तो डॉक्टर हूँ और मुझे इतना सब ज्यादा पता नहीं है, मेरे सब administrative चीजें कोई और देखता है. Nobody is going to spare us. Nobody has ever spared any doctors, right? So 72-hour rule has to be remembered. And then what happens to the research data? Using patient data for research. This is again very important, especially when we are in government hospital and in teaching. It's very important using patient data for research without explicit consent and ethical clearance. Ethical board जो भी होता है hospital का, without their consent is now a criminal offense once this comes in play. So anyways, in the medical colleges, in the hospitals, we have ethical board or ethical and scientific committee, which needs to approve that this particular data is being used for research purpose. It's not very difficult. It's not even scary or whatever. This is just you sticking to rule for being safe in your skin, right? So this is where, so your digital identity, so that's something which is important. Coming to the next part, which is digital identity and patient journey in action. Why? So this we just talked about health professional registry. So why do we need to? This is a separate. Now we are coming from DPDP to the health professional registry. When we register as health professional or register under the health professional, registry. One is you have a verified National Medical Council's linked credential in the national health ecosystem. So you are a visible healthcare professional. Of course, we are visible with our work, and we always believe that हम डॉक्टर हैं और हम अपने नाम से नहीं अपने काम से जाना चाहते हैं. Still, when we come to a national platform, we need to have our name out there in the ecosystem. That's one. Enables ABDM linked digital prescriptions and structured referrals. So if you are keen on practicing digital health, this is something which you need to have. Then mandatory for DHR's financial incentive scheme, which is, so professionals registry gives you a financial incentive as well. It is required for AI-assisted EMR tools in ABDM certified ecosystem. Access NHA Academy. So now this is something which is new. National Health Authority is coming up with the academy, or it is like Swayam portal, or those of us who are in government system, they are aware of Karmayogi Bharat, which is again a skill development thing, where you have free of cost courses which you can take and upskill yourself. NHA is coming with the NHA Academy, which is again a digital academy where you will have digital health and AI related learning for doctors especially, along with CME, national CME credits. So we can be a part of that. And then Foundation for India's first healthcare workforce registry for policy and planning. It is a very, very important national task that we need to be a part of. So here is the patient journey really. Aadhaar ID can be created at a PHC, followed by a digital reference, no paper lost in the transit. Coming to a GMC OPD maybe, where you can scan and share, the time is saved, the patient is at peace. And then probably if the patient wants to come to a specialty healthcare facility, which is not even government, it's private, but it is state of art, and he is free to do that. Through Aadhaar ID, he can actually have an access to specialist, right? So no repeated tests, etc. Everything comes to the specialist healthcare setup, and the patient is at the center of everything. Coming to the next section, which is, let's just have a little bit of facts. So the word algorithm, which we use nowadays very often, comes from Al-Khwarizmi, which is a 9th century Muslim scholar from Persia. He has put that in. So AI is not just today, it has its ancient root, and the words that we are using today have their ancient roots, right? So India's next would be, these are some of the facts which I had kept so that it doesn't get boring. But Cure AI is something which we had heard of. I don't know, but it is something which is working on chest X-rays and tuberculosis. So it is deployed 20 plus countries and has successfully screened millions of patients with tuberculosis. Right. Then there are some more interesting facts. We can maybe skip it for now and then come to the AI in healthcare, from simple to sophisticated or higher grade. Right now, probably we are on level 1, of AI, which is administrative. Appointment scheduling, billing, reminders, right? SMS. Then there can be fraud detection that is happening in the claims, etc. Which is very useful. So this is grade 1 or level 1 basic AI. But coming to level 2, which is diagnostic, that's also happening. That's also, I'm sure in this hospital you are using. I don't know if you can help me.
Yes, with that.
Right. So yes, thank you. That really helps. So yes, so diagnostics AI, that comes at level 2, and not all the hospitals and healthcare facilities are right now at this level. There are few who are leading this revolution as well, Paras Healthcare being one. So triage, tuberculosis, COVID, then ECG interpretation is something which is happening at a large scale. Then diabetic retinopathy screening, skin lesions, etc. at the periphery. This is level 2. Everybody is using at level 1. Some of the hospitals which are leading in this, they are using level 2, and even some private clinics nowadays. Coming to the third level, which has its own pros and cons, which is clinical decision support system, right? So early warning of sepsis in ICUs, then there is drug-drug interaction, then differential diagnosis engines, treatment pathways, etc. So this is clinical decision support system, which is created to assist the clinicians, not really supersede the clinicians or sit on their heads. But this is level 3 and this is more sophisticated and this is still undergoing a lot of development. Level 4 is predictive AI, where you have, public health, people like me, population health risk, stratification, outbreak forecasting, and things like that, or modeling for a particular. All of us remember during COVID, they generated multiple models and they predicted first wave, whatever second wave, this, that. None of the models and none of the predictions really fit. And what could be the reason really? क्या कारण था?
So any kind of predictive AI is we need a humongous amount of data to be fed onto that. COVID was something that struck us very quickly. And then we didn't have the information prior to that. We didn't have any patterns to feed it. It's not convoluted networking when you acquire the prediction. It's the higher level of the networking. So the data that was fed was very raw. It was very small. So obviously the results that we get are not reliable.
Yes, thank you so much for that. And that was precisely one of the, yes, let's just, thank you. So that was one of the reasons, which was, the largest reason was that we did not have any precedence, and the data that we fed was not fed by doctors. Doctors were busy actually treating the people who were dying, while the data and the models were created by non-doctors, probably the engineers, who do not understand the social, the cultural, the ground level problems with which the patients come in. Right? So when the models were created, all these factors were not really considered. How would the model work for us, right? Yeah, so that's predictive. And next level or last or higher level would be, sorry, what time would that be? Please let me know at any point of time, we'll rush quickly. Right. Last level would be, ambient scribes and synthetic data for research, personalized medical education, and AI care planning. So the thing that we're talking about is, the personalized medication, ambient scribe, where you and your patient sit in your OPD, you talk, and the scribe or the model or the tool just picks up whatever is needed, whatever is, relevant, and creates a history, creates a page for the particular patient, and based on that, supports the clinical decision making, supports the diagnostics, recommends the diagnostic, tests, etc., sends necessary notifications and things like that till the administrative level. So that's generative AI, generative AI, and then creating synthetic data for research, when you do not need to have, like ma'am just mentioned, we did not have any data for COVID. And now we are talking about generating data for research so that the model becomes better and better. So we haven't yet, so we are right now at healthcare, we are really largely sitting at, level 1, 2 and 3 to a certain extent, but predictive AI is not yet very, very crisp, and generative AI ke liye for healthcare, it will take time. And it will take some of us, some of the doctors who are clued up in this, some of the doctors who are ready to work with the engineers who are doing this, so that whatever the outcome or the product that comes out is much more useful for us in India, in our regional population. Some of the radiology and TB screening directly relevant. Cure AI is one of those things which are sensitive. 90% से भी ज़्यादा pulmonary tuberculosis sensitivity is there. 30 plus countries it is already being used, and it is integrated with our Nikshay portal. Right? Then there is Vadbani AI as well for tuberculosis. Vadbani AI is doing a lot of work along with Government of India again. So building, Indian PHC data, works on low-end Android. So they are a lot in public health and periphery, offline capabilities, and smear microscopy errors, etc. can be flagged, etc. Then there is PET-CT and oncology and things like that. AI detected, active tuberculosis from chest X-ray with 94% sensitivity in 2024 in a study. It is a multicentric Indian study, and it outperformed our junior residents at 2 a.m. right? So this is what we're talking about, how AI can support us so that our residents don't have to really sit at 2 a.m. and do this, first of all, and they can be assisted with all those NAD, chest X-ray, NAD, right? Yes, so we can actually help with, burnout of the clinicians. Coming to another scenario, a 52-year-old man from Kupwara, PHC, arrives at this hospital. His chest X-ray is auto-uploaded, and the AI tool flags a right upper lobe infiltration with 87% confidence of tuberculosis. Now, system auto-generates a CPNAT request and an X-ray notification. He is a smoker with type 2 मतलब बंदा क्या ही कर रहा है ना, तो type 2 diabetes and reports no fever. As the attending, what is the correct next action? Anybody can just, yes.
I will review the AI flag along with clinical context, history, and then decide.
Right. Let's just, anyone else wants to give it a go? Yes?
Option C.
Yes, let's see. Yes, well, of course. I mean, review AI flag alongside the clinical content and then decide. So, AI is never going to replace a doctor, a clinician, an experienced one at that. It's going to assist, but it cannot replace. We need to be in the loop. They're saying, मतलब बहुत सारे बार they're saying कि doctors are scared that we will go out of. We're never scared, obviously. Because that's not going to be possible. You have to be alongside that AI model to make the model work. The model is never going to be constant or मतलब पत्थर की लकीर नहीं है वो. The model learns on itself and on its mistakes as well. You need to have a clinician alongside the model for the model to keep working as well. Right? So, case, of course, let's not go through the details, but then option A is reckless. What was that? Trust the AI, जो भी कर रहा है करने दो, मैं साथ में बैठ के मतलब I'll have my cup of tea, वो नहीं होगा. Option B throws away the valuable data, जो कि था, override the AI, 87 days not high enough, wait for the radiology to review. क्यों ऐसा करना? We need to make the best use of the given AI, right? Option D is absurd. Right, and then option C reflects the responsible AI use, and then we come to the critical care and ambient scribe, which we talked about just now. Sepsis early warning AI, this is existing right now in many of the hospitals, tertiary care hospitals. So early detection, early warning of sepsis, and some other things as well. Chronic kidney diseases में ये use हो रहा है and things like that. So T-6 hours, AI detects subtle vital trends which are flagged. Then the nursing team is alerted. T-3 hours, cultures sent proactively before clinical picture worsens. T-1 hour, CDS, clinical decision support system recommends an antibiotic bundle, and clinician reviews and then approves. And at T0, sepsis is confirmed, patient already on treatment, and lives are saved with this. So this is one of the ways that we can effectively use AI here. Coming to ambient scribe, which we talked about just now, where you are sitting with your patient and the scribe is, capturing the relevant and required data. Here, let me just tell you about digitalization in AI. Now, people were talking about digitalization and they were complaining. The doctors were complaining that we don't want to sit in front of the screens. We want to talk to our patients. Our patients connect with us when they speak with us face to face. When I'm looking into the eyes of a lady who is traveling from some distance, she wants me to look at her, speak with her, only that heals her. Not just the medicine. So here, and then, we were made to kind of sit in front of a computer, type the symptoms, type the history. वो सब नहीं होगा. Doctors are not for that. What we are for is really, spend more time with our patients. 40% of clinical time is spent on documentation, some form or the other. Ambient AI scribe listens, transcribes, and draft notes in real time. SOAP format, there is like whatever symptoms, etc., etc. And it is ABDM compliant again. So first it is listening, then it is transcribing, drafting some of the notes, etc. Then it is reviewing, and then it's filing and doing a lot of administrative work. What is the result? More time for the patient, less time for the keyboard. We can actually become more efficient when we use some of these tools. But then, of course, there are some drawbacks to this right now. The ambient AI or the scribe, etc., needs to be DPDP compliant as well. So when we are actually looking at a solution which we want to adopt in a hospital facility, in a healthcare facility, needs to be DPDP compliant. It cannot be just FDA approved, or it cannot be just approved by a European authority. Has to be approved in India by India, and we'll come back to it later. Coming to this, which is tactical AI. AI. Some of these solutions really, we don't have to really go into the details. This is just what I have made a little bit of list, which we can easily use, right? So AI portable ultrasound, but then ultrasound, when we are looking at portable ultrasound, there are always some of the ethical and legal risks because of which we are not very open to use portable ultrasound. But ECG AI, then offline first EMR, then medvac, etc. So these are some. But then eSanjeevani, are we using eSanjeevani here?
Yes.
We are in the in periphery, right? Yes. So this eSanjeevani again is one of the best telemedicine.
We use ECG.
Oh, great! That's amazing. So how has been the experience? Sorry, how has been the experience?
With the Tricop
Yes. Yes.
Exceptional. I mean, I'm sitting in the cafeteria having a coffee. My paramedic is performing the ECG. I get the real-time feed on my phone, and by the grace of Almighty, there's a group of doctors in Kashmir and across the globe, Kashmiri origin, cardiologists.
Yes.
They've formulated a group called Save Heart Initiative,
So
local and global. So you post the ECG in any of those groups, round the clock, anyone would be awake, and they will
give a feedback on that, or give.
besides what AI gives us.
That's superb, isn't it?
And you just said 94% sensitivity in the
Previous.
CSR.
Yes.
Where you said it outperforms the JR. I think we're there in the sensitivity range of 94 to 98 PLU.
That's because of the cardiologist in the loop.
Rechecking.
Very nice.
Confirming.
Yes, so amazing. This is actually something which which we need to bring out.
That's 6 MIs diagnosed in past 1 month.
That's a success story. That's an absolute success story. And in fact, I don't know, you've already documented it.
Yes, Dr. Shalim is there in GMC Anantnag. Dr. Mahmood is there in GMC Anantnag. Then there is Dr. Irfan in GMC Srinagar, I think, SSH. So they are the guys who are running this group. I mean, they encourage people from peripheries, from the remotest parts to post ECGs. Not only those Tricop ECGs, the routine
ECGs as well.
Trust me, in the past 1 decade, I think, they've made thrombolysis AI. Thrombolysis, they've made an order of the day. Nobody comes to the tertiary care institutes without thrombolysis. Barely anyone.
That's a huge success, because in that situation, time is everything.
अभी तो हेल्थ भी स्टार्ट कर दिया सेफ ब्रेन इनिशिएटिव करके.
We have a class in cardiac sciences, so you can add some comments for it.
Yes, absolutely.
Yeah, this is actually a group created by the local Kashmiri doctors. It's working in Kashmir. Any physician, resident who is in periphery, he hears a patient with chest pain, they just post the ECG, they will get the response whether this patient needs thrombolysis. That's actually the motive, to save time.
And in fact, I'm sure because it's all doctors, you always post an anonymized data. There is no divulging the patient details there. So that's like a completely secure.
Sex and age. No name.
I think this group was created at the time when there was no concept of
There was
two startups.
Yeah.
Oh, wow.
It was just ingenious effort that the Kashmir doctors and the ISPA took.
I'm on your sixth
And it
floor.
became really
I'm on your sixth
impactful and meaningful.
I'm on the sixth
But
floor.
that's something which is, which rest of the world also needs to be,
COVID onwards, they included the doctors from army
Sixth floor.
and the paramilitary. And believe me,
Come
a
on.
lot of casualties were saved.
So maybe I think in question answer session we can take.
yeah, we can take this as a separate, because this is completely the use case for one of these things. And this, how old is this, sir? This initiative? Decades old. So this is even before any AI or any startup or any digitalization came in. This is purely human in the loop, which is saving the life. And let's just say when you add a layer of technology to it, for example, the particular, the tool, the software, you have added efficiency. Imagine.
This is when the WhatsApp permitted only 100 members per group.
Oh.
So we had say what 1, say what 2, say what 3, say what 4.
Oh my God.
It's like that.
That's amazing. That's amazing. And that is what we need to really build on. We need to build on existing networks. We need to build on existing platforms and make them more efficient. That's amazing to hear from you, sir. That's thank you so much.
Thank you.
Right. And then coming to very sensitive maternal and child health, again, JNK is doing much better than the national, indicators in maternal child health, and we can actually improve on that as well. So for that, predictive risk scoring for preeclampsia maybe, or IUGR, high risk flagging can be done with the use of an AI tool. Coming to the, not the last, but the most important, as I feel, the part of the whole presentation, which is responsible use of AI. Now the question today is not, can I use AI to do this, or can AI do this? It is the question that we need to ask is, should AI do this, or should I myself be in the position? Right? So should AI do this? That's the question that we need to ask, because there are algorithmic biases, right? So AI is trained many a times. Many of these tools which come to us, many of the vendors that are coming to us are AI, are having the data, like Madam just mentioned, the data was not enough or the data was not good enough. It is not the Indian data or our kind of data, our regional data. It is trained on Western data. Let's say it is trained on urban data or some other populations which may systematically misdiagnose the patient from rural areas, from a particular ethnicity, from tribal communities, or various. India is diverse country, so we need to be very cognizant of what the data is trained on, what data the model is trained on. That's something which is extremely important, because when we go digital, the errors or the biases which if they exist in the model, they get amplified like none other, and we are not talking about any financial loss here. We're talking about loss of life. When there are mistakes or errors in healthcare models, the life which is at stake, not somebody's money. Of course, there is a lot of money, but yes, right? So data. Then second is data sovereignty. Patient health data is national asset, allowing foreign AI companies to process Indian healthcare data without safeguard, violates again the act. And of course, it is not safe, right? So, national security, compromises national security. So, जो servers हैं, ये सारे models के, ये सारे tools के, they need to be situated in India, in our land, whatever. Then coming to clinical de-skilling. What is that? Over-reliance, de-skilling. Over-reliance on AI without understanding its limits creates clinicians who cannot function without these models. We don't want to do that. We don't want to create dumb clinicians going forward. We want to sharpen our juniors, our residents, doctors of our future generation doctors need to be smarter than what we have been. I mean, not very smart we have been, but we have to continue that. So, clinical de-skilling cannot happen with AI. Accountability gap. Who's responsible? When AI contributes to wrong diagnosis, who's responsible? Do I say tomorrow to this family who loses the head of the family that AI model that I used was responsible? No, we're going to get a hit on our head if we say that. AI is not responsible, the vendor is not responsible, even the hospital is not responsible, it is the doctor. And that's why we need to be aware, right? AI company, no. Under law today, it's you as a doctor who's responsible, right? Then equity paradox. Poorly governed AI can widen the health disparities. They say India lives in many centuries at a time. कहीं पे we are really modernized, and the cities are so modern. कोई first world country, developed country में भी ऐसी सुविधाएं नहीं हैं जैसी हमारे यहाँ हैं. At the same time, some of the places are really living in ancient times even today. That kind of country we live in. So, when we are adopting digitalization or AI, we cannot really widen or worsen this gap. We need to really fill the gap with digitalization. So, we always need to be cognizant. And then coming to research ethic, AI-powered research using patient data without explicit consent, ethics, approval and compliance of DPDP is now going to be criminal in India. Coming to the outcome of India AI Impact Summit, SAHI, which is the strategy for artificial intelligence in healthcare for India, SAHI. It answers many of the what is safe, accountable, equitable AI tool look like in the Indian healthcare context. Let's just take a look at the 6 pillars of, 6 pillars, actually there are 6 pillars and 32 recommendations. Anybody has gone through this document before, Sahi? This is recent, February 2026. This was one of the Sahi and both these. So both is a lot of medtech related, strategy, while Sahi is the healthcare related strategy. And at the center of it is patient. So it's all patient centered. Governance and regulation, trust, which is the most important. Then health data, digital infrastructure, etc. Workforce capability and change management. Here, this is pillar 3, which is, center of all these 5 pillars and which becomes the center of the whole strategy as well. Keep aside the data, keep aside the governance or even research. The mindset change or change in the mindset of the people who are going to use this tool or AI or digitalization is the key to digital transformation. So, capacity building for doctors, even for our ethical committees, which are right now, taking these researches, which are AI driven, they are not yet capable of really evaluating these kind of healthcare researches, which use a lot of AI, right? So, we need to really have the capacity building to be done. Coming to another problem which comes with digitalization or AI is the black box problem. What happens in between the input and the output? We are not very sure, right? The black box in between. Algorithmic opacity in the clinical care, we cannot trust it. We cannot deal with any kind of unknown when it comes to health outcome or when it comes to life, right? What data was, so how do we really, deal with it when somebody comes up with a solution for, a particular healthcare problem? Ask certain questions. What data was it trained on? Please ask these questions freely. Don't feel that the friend of yours who's from IT sector will feel offended. No, these are basic questions. What was the data? It was trained on Western hospital populations may not be, reflecting, let's say, Kashmiri or Gujjar, Bakarwal demography. etc. Diet patterns are different, the genetic makeup factors are different, cultural factors are different. So please ask this question. What does it optimize for? A high sensitivity, and at the same time you need to have high specificity as well. Otherwise there is something called as alert fatigue. जैसे आप अगर जैसे सर अभी कह रहे थे कि मैं कैफेटेरिया में बैठा हूं और 10 मिनट में अगर मुझे 10 कॉल आ गए नर्सिंग स्टेशन से, सर पेशेंट ने ब्रीथ कर लिया, सर पेशेंट को हिस्की आ गई, सर पेशेंट को ये, आई एम गोइंग टू गेट फटीग्ड मेंटली. मैं कॉफी पीऊं कि ये करूं, तो आई माइट एज वेल बी एट माय स्टेशन इंस्टेड. सो alert fatigue can also be set in by these models where any smallest of the variation is alerted to the highest of the authority. So that also is not correct, right? So specificity matters as much as sensitivity in clinical reality when it comes to reality, right? Then next question to ask is, when does it fail? ये कहाँ तक, इसके मतलब दायरा कितना है, लिमिट्स क्या है इसके, ये पूछना बहुत जरूरी है. Out of distribution inputs, rare presentation, cultural illnesses, narratives, then altitude, बहुत extreme levels पे आपका मॉडल अगर जनरल पॉपुलेशन के लिए ट्रेन है तो कोई niche population पे it may not work and not give right kind of results. Then who is accountable for errors? Again, coming back to this DPDP, prescribing clinician remains medico-legally responsible, not the vendor, not the hospital CEO, it is you. Last but one. Okay. So, leading hospital chain wants to deploy an AI tool trained exclusively for 5 lakh US patient records. The vendor claims it is FDA approved and ready to use. The hospital administrator asks you, the medical superintendent, to sign off. The AI will be used for triage decision at your J&K unitary facility. Based on SAHI principles and your responsibility, what should you do? These are the 4 options. And of course, FDA approval is not CDSCO approval. Yes, who said C? Yes. US validation is not Indian validation. Please know the difference. Everything coming from US need not be the best and the most suitable for us. Yes, answer C. Request Indian validation data and compliance of DPDP, which is the right thing. FDA approved approval is for the US market, does not account for Indian demography, disease prevalence, and the physiology, etc. So he requires Indian validation data. Right? So clinicians, ethical governance framework, there has to be transparency. Ask, can I explain this AI recommendation to my patient in plain local language? I'm saying Urdu here, but whichever language, of course not Gujri or anything, we're not going to say that, but then at least when we are talking about, we need to have a regional language, right? Accountability. Who's responsible if the recommendation harms a patient today? Ask this blatantly, do not hold back, right? Privacy. Ask if patient consent documented. Is this DPDP and SAHI? SAHI is not a compliance, it's a guideline. So we cannot say that it is compliant with SAHI, but DPDP is going to be an act, so we can definitely question. And of course, we can definitely ask about ABDM compliance, right? So then fairness. Was this validated on population like the ones which we have in our ward? This is a question that a doctor needs to ask. Safety. What is the failure mode? When must I override this tool? These are the questions. And beneficiaries. Does this genuinely improve the outcome? They'll always say yes. Not just hospital efficiency metrics. But then obviously this is a question that you need to ask yourself, not the vendor. He's always going to say yes. Right? Some of those things which we want to really go through. Using AI for diagnostics. So what is the risk level here? Using AI for diagnostics, high level, violation if consent not documented. AI for diagnostics. Sharing anonymized data for research, again, check with ethics committee first. I'm not going through the middle column. Then EMR system, it is medium level. Alright, verify with your IT vendor, IT team, कि ये सही है, नहीं है, compliant है. Telemedicine consultation, again medium. Update the consent and workflows. And then WhatsApp for patient. Let me just tell you, WhatsApp for patient reports, etc. It has got high, risk level. So you need to stop immediately. Use Abha sharing, which is very easy nowadays, right? There are separate apps. Coming to capacity building the digital cadre, let's say. What was that? So this is my experience really. We developed a certificate course in digital health. That was one of the first in India, which was with IIT Bombay and Maharashtra University of Health Sciences. Why was this course developed? There is a gap. Clinicians were being, handed digital tools that they did not understand or could not even critique. And they were afraid to really question. Technology was, leading the medicine. That is not the way we wanted. We need to lead the technology that we want for our use. They came to me, some of the people would come to me and say, this is the solution I have, do you have a problem? This is not the order. You want to give the problem to the technology, and the technology should create a solution which fits your hand. There is no disruption when it comes to healthcare. They talk about this new term, disruption, and it's a positive term. I mean, it was very surprising for me. Disruption in healthcare cannot be positive. We already have a lot of disruption going in our clinical, emergencies, in our ICUs. We have a lot of chaos happening any time we enter. We don't need much more disruption. We need something which fits in our workflows, right? Yes. So the mission was moving the Indian healthcare workforce from digital literacy, which is, knowing the tools which exist, to digital fluency, using them critically and confidently in the practice. And then, of course, MUHS, Maharashtra University, we have some 670 healthcare institutes under us, and some 60,000 healthcare professionals. Along with KCDH, Kota Center for Digital Health at IIT Bombay. So we created this course, and then the technology does not fail, implementation fails when the human in the loop is not trained, right? So training the doctor in the language that the engineer understands, so that we convey our difficulty, our problem in a right manner, so that we get a solution which we want. Right, so that is something which was at the basic of this course. It is it is one of the first courses. First cohort is already out. There are some more courses which we developed, which were self-paced and which are available right now on I Got Karmayogi. There are 7.5 lakh healthcare professionals across the country who have taken the course, because it has got 13 modules. And it's Digital Health Foundation course. You can take, go to Karmayogi Bharat, I Got Karmayogi, and take this course. First module मैंने बात की है, तो आपने अगर वो देख लिया तो मेरा rating भी बढ़ जाता है ऐसे. So not really that, but yeah. So it's one of the very basic understanding of digital health. You can take it. Then there was certificate course. We also created a Digital Health Foundation course for nurses. Because nursing profession they already have a topic or subject called healthcare informatics in their curriculum. Unlike medical curriculum, जहाँ पे digital का अभी कुछ नहीं है, मतलब कुछ सिखाया नहीं जाता, nurses को सिखाया जाता है. तो based on that curriculum, we created a separate Digital Health Foundation course for nurses as well. That is also available on Karmayogi Bharat, and now it will be available on NHA Academy as well. Layered capacity building, or what we say, competency based capacity building. So सब लोगों ने सब कुछ जानना जरूरी नहीं है, ना possible है. So those who need particular tools need to learn about those. So HODs, policy makers, governance, they need to know certain, need to have certain understanding of digital health and AI, while consultants who are in private practice, specialists, etc., their understanding should be from a different domain of AI. RMOs, residents, so that's something which we have addressed in the textbook which I have given just now. Then coming to PHC doctors, paramedics, etc., they need to understand certain other tools like e-Sanjeevani, triaging, telemedicine, etc. Coming down to the community health workers, our ASHA and Anganwadi workers, etc., they also need to be trained in digital and AI tools, right? And the last but not the least, what we can do, and this is the last one I promise, by 2030, what percentage of clinical decision in India's public health system will likely involve AI support for of some kind? This is, yeah, you can just, not AI replacement, I'm saying AI support, training, flagging, suggesting, documenting, predicting, etc. You can say something.
See, the rate at which the public health system is adopting it is really very good. So,
Okay.
40 to 80%.
How much does your clinical practice currently uses, or touches the an algorithm? Yes. Okay. So, if ABDM adoption continues and, we do not enforce, obviously in India, we do not enforce anything anytime. It has to be adopted willfully and, हमारे समय से, अपने समय से, धीरे धीरे पहले पेशेंट को फिर हमको, बट ऐसा नहीं होना चाहिए, पहले डॉक्टर्स ने अडॉप्ट करना चाहिए तब जाके पेशेंट्स करेंगे. So this is just something, and you know this better than I do. Digital prescription, 6 actions that we can actually do today. One is, अगर आपने अभी तक हेल्थ प्रोफेशनल रजिस्ट्री में नहीं रजिस्टर कराया तो कर लीजिए, इसमें 10 मिनट शायद लगते होंगे, कम ही लगते हैं वैसे. Digital medical identity for India's health ecosystem. So all doctors, nursing professionals, please आपकी जो नर्सिंग टीम है या आपके टेक्नीशियंस हैं उनको भी आप बताइएगा, ये कर लीजिएगा. Then interoperable EMR. Interoperable EMR is something which you need to do this. I'm saying this month, but जब भी possible है. But obviously Paras में you already have this in place, which is something that is why I said ahead of the curve. Right. Lead an innovation cluster. One clinician, one engineer, one patient representative. Patient representative as in one of the NGO. It can be an NGO. It can be a patient. जैसे sickle cell वगैरह हमारी तरफ है, तो sickle cell patients के जो caregivers हैं, उनका अपना एक group है या caregivers का group है, तो their representation. Create this. That is how we started at MUHS IIT, and then with this you invite the startups which are booming right now. Evaluate these startups and give visibility or give platform to the Indian startups which are working in healthcare. Right? This is how we lead a team. We are built to see doctors or healthcare professionals are generally built to lead a team. Engineers are trained. By training, they are trained to work in teams. We are trained alone. अकेले पढ़ाई भी, of course we have group studies and all, but when you're trained to lead a team of healthcare professionals, right? In any situation, chaos bhi ho, emergency bhi ho, you are naturally trained to lead that team, and why not bring that leadership in this ecosystem as well, so that we lead an innovation cluster. Each one of us here, we can actually do that because we have our own network. तो उसमें एक इंजीनियर बंदे को ले लेंगे, उसमें एक NGO को ले लेंगे, एक patient whatever representation group को ले लेंगे. Please try this, and this would be really helpful. NHA Academy का कोई मॉड्यूल या फिर I got कर्मयोगी, something new to learn about digital health. Adopt सही compliant AI, वो आपके ऊपर है. And then the last thing but not the least, very critical, very important, all doctors are all the time aspiring, which is publish. As early as you can, start publishing. If you're already using AI, start reading, start documenting. जैसे मैंने अभी कहा, this is a use case, this is a success story. Start publishing. As much Indian stories come out, better it is for the world and for us, right? So your observations on AI, and that gives the world, a benchmark. We do much, much better than many other countries across the globe, but we are not really documenting it that sophisticatedly. So we need to do that. So your observations, especially niche population जो JNK का है, that will be immensely valuable, right? And what are some of the key takeaways? You are already ahead of the curve. You are now the data fiduciary. So every patient, whatever. Anyways, then coming to AI augmentation, you are deciding. You are in, authority, right? Responsible AI is never an option. It has to be the first every time. You must lead this revolution from front. You can't be one of them. You can't be just lagging behind. You need to, as a doctor, you need to be ahead. You need to be the leader. Sahaviryam Karvavahe, may we work together with great energy and vigor. That's what we are talking about. We need to, strengthen, empower our own community. Thank you so much. This is another event which I'm a part of. So multiple groups that I'm a part of. So Doctors AI is again a global community of doctors who are already in AI. You can join this one. They have a global summit in Delhi in September 20th, 19-20 September, which is interesting. Last year it was in Bangalore and it had really nice this thing. Also, okay, anybody wants to? Yeah. Sorry, right. And the other thing which I would really like to bring to your notice, this is a new journal, Artificial Intelligence in Medicine. There are few journals right now. There are generally, engineering side of journals. Here, this is a new journal. This is by JP publication. The same that the textbook is published. This is new journal. First issue will be coming in June. Because it is new, they will right now take the articles even if it's not like, the best, etc. Or if it is a little older article, right, based on older data. And you can, there are two ways that I would really like to, involve you. One is you can actually send your residents, etc. This thing and ask them to submit their research, anything. And the second is become a reviewer for this one. Earlier you start reviewing the AI related research, better it is for you to kind of, start understanding that space. Earlier the better. And there are very few clinicians who are working actively, and you can be one of the, torch bearers or leaders in the space AI in healthcare or AI in medical faculties. So that is that. Thank you so much. Thank you for this opportunity.
Thank you so much.